Chapter 11, Airway Management. Your national standard competencies for airway management, respiration, and artificial ventilation applies knowledge, fundamental depth, and foundational breadth of upper airway anatomy and physiology to patient assessment and management in order to assure a patent airway, adequate mechanical ventilation, and respiration for patients of all ages. Airway management is going to cover airway anatomy, airway assessment, and techniques of assuring a patent airway. Respiration is the anatomy of the respiratory system, physiology and pathophysiology of respiration, pulmonary ventilation, and oxygenation. External, internal, and cellular respiration. Assessment and management of adequate and inadequate respiration, supplemental oxygen therapy. Artificial ventilation is assessment and management of adequate and inadequate ventilation. Covers artificial ventilation, minute ventilation, alveolar ventilation, and effect of artificial ventilation on cardiac output. Pathophysiology applies comprehensive knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. The most important steps in caring for any patient is obtaining and maintaining a patent airway and ensuring that the patient is breathing adequately. Oxygen reaches body tissues and cells through breathing and circulation. During inhalation, oxygen moves from the atmosphere into our lungs. Carbon dioxide leaves the body during exhalation. Primary objective of emergency care is to ensure optimal ventilation. Basic airway management skills tend to be taken for granted. They are among the most crucial skills any EMS provider learns. Anatomy review. Respiratory system consists of all the structures in the body that make up the airway and help us breathe. Airway is divided into the upper and lower airway. Structures that help us breathe include the diaphragm, muscles of the chest wall, accessory muscles of breathing, and nerves from the brain and spinal cord to those muscles. Ventilation is the exchange of air between the lungs and the environment. The diaphragm and muscles of the chest wall are responsible for the regular rise and fall of the chest. This figure shows the structures of the upper and lower airways. The upper airway, the larynx, is considered the dividing line between the upper and lower airways. Major functions of the upper airway are to warm, filter, and humidify air brought into the body. The pharynx is composed of the nasopharynx, oropharynx, and laryngopharynx. The laryngopharynx is the lowest portion of the pharynx. This figure shows the oral cavity in the pharynx. The nasopharynx is the union of facial bones that form that. They are divided by the septum. Nasopharynx is lined with a ciliated mucosal membrane. Cilia help move contaminants out of the body. From lateral walls of the nose, 3 bony shelves called turbinates extend into the nasal passageway. Sinuses are cavities formed by cranial bones. Fractures of certain sinus bones may cause a leakage of cerebrospinal fluid into the nasal passageways and auditory canal. The tissues of the nasopharynx are extremely delicate and highly vascular. The oropharynx is the part of the throat found at the posterior of the oral cavity. The epiglottis is a leaf-shaped cartilage flap located at the base of the tongue and above the larynx. Combined with closure of the vocal cords, these actions protect the airway from aspiration during eating and drinking. The larynx is a complex structure formed by many independent cartilage structures that all work together. The main laryngeal structure is the thyroid cartilage. The glottic opening is the narrowest portion of the adult trachea. Airway patency depends heavily on muscle tone, and airway devices are occasionally inadvertently inserted into the piriform fossa. Uh, the function of the lower anatomy is to exchange oxygen and carbon dioxide. External boundaries are the fourth cervical vertebrae in the xiphoid process. The trachea, or the windpipe, is the conduit for air entry into the lungs. When the trachea reaches the thoracic cavity, it divides at the level of the carina. The lungs include the smaller bronchi, bronchioles, and alveoli, and that is a picture of those. All lung tissue is covered with a thin, slippery outer membrane called the visceral pleura. The parietal pleura lines the inside of the thoracic cavity. On entering the lungs, each bronchus divides into increasingly smaller bronchi, which subdivide into bronchioles. Bronchioles are thin, hollow tubes made of smooth muscle. Smaller bronchioles branch into alveolar ducts that end at the alveolar sacs. The alveoli serve as the functional site for the exchange of oxygen and carbon dioxide. Oxygen diffuses through the lining of the alveoli into the pulmonary capillaries. Surfactant lines the alveoli. This decreases surface tension and helps keep the alveoli expanded. In the amount of surfactant is inadequate or the alveoli are not inflated, the alveoli collapse, which results in atelectasis. Between the lungs is a space called the mediastinum, which is surrounded by tough connective tissue. This contains the heart, the great vessels, the esophagus, the trachea, the major bronchi, and many nerves. Phrenic nerve innervates the diaphragmatic muscle, allowing it to contract. Physiology of breathing. Respiratory and cardiovascular systems work together. This ensures a constant supply of oxygen and nutrients to every cell in the body. It ensures that carbon dioxide and waste products are removed from every cell in the body. It's important to understand how the processes of breathing and circulation are connected. The heart pumps blood to the tissues of the body through a series of arteries and veins. Arteries carry oxygenated blood away from the heart and branch into arterioles and capillaries. Oxygen and nutrients leave the capillaries and enter the cells. Waste products diffuse from the cells back into the blood of the capillaries. All veins, except the pulmonary vein, carry deoxygenated blood to the heart. Deoxygenated blood enters the right side of the heart through the right atrium. When one system is compromised, oxygen delivery is not effective and cellular death could result. Every cell in the body needs a constant supply of oxygen to survive. Sufficient levels of external ventilation and perfusion are required to deliver adequate amounts of oxygen to the tissues of the body. Ventilation, the process of moving air into and out of the lungs. It is necessary for oxygenation and respiration. It is essential for life. High priority in treating any patients. If a patient is not breathing adequately, immediately intervene to ensure adequate ventilation. Inhalation is active muscular part of breathing. Air enters the body through the mouth and nose and moves to the trachea. The diaphragm and intercostal muscles contract. Maximum inspiration occurs when the diaphragm and intercostal muscles are contracted and the lungs fill with air. The lungs have no muscle tissue and cannot move on their own. The ability of the lungs to function properly is dependent on the movement of the chest and supporting structure. These are the thorax, thoracic cage, diaphragm, and accessory muscles. The diaphragm is a specialized skeletal muscle. It functions as both a voluntary and involuntary muscle and also performs an automatic function. Partial pressure. This describes the amount of gas in air or dissolved in fluids such as blood. It is measured in millimeters of mercury. Body attempts to equalize the partial pressure, which results in oxygen diffusion across the membrane into the blood. Atmospheric pressure is normally higher than the air pressure within the thorax. During inhalation, a slight vacuum is created. Gases such as oxygen will move from an area of higher pressure to an area of lower pressure until the pressures are equal. The entire process of inspiration is focused on delivering oxygen to the alveoli. Table 11.2 reviews ventilation terminologies. Variations in tidal volume, respiratory rate, or both will affect the minute volume. Exhalation. This does not require muscular effort. It is a passive process. The Herring-Brewer reflex is the feedback loop or combination of mechanical and neural control. Relaxation of the diaphragm and intercostal muscles increases intrapulmonary pressure. When the size of the thoracic cage decreases, air in the lungs is compressed into a smaller space, increasing the air pressure. Maximum expiration occurs when the diaphragm and intercostal muscles relax and air is exhaled forcefully as opposed to the normal passive process. Clearing and maintaining an open airway is crucial. Maintaining the airway means keeping the airway patent. Air may also pass into the chest cavity through an abnormal opening in the throat or chest wall as the result of trauma. Regulation of ventilation. The body's need for oxygen is dynamic. Regulation of ventilation involves a complex series of receptors and feedback loops. For most people, the drive to breathe is based on pH changes in the blood and CSF. In healthy people, when the oxygen level rises, the respiratory center suspends respiration until a rising carbon dioxide level stimulates the respiratory center. Oxygenation, the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. Adequate oxygenation is required for internal respiration to take place. At high altitudes, atmospheric pressure makes it difficult to breathe sufficient amounts of oxygen into the body. Respiration, metabolism, or cellular respiration. Cells take energy from nutrients through a series of chemical processes. During metabolism, each cell combines nutrients and oxygen and produces energy and waste products. Each cell in the body requires a continuous supply of oxygen and a regular means of disposing of waste. Respiration is the process of exchanging oxygen and carbon dioxide, and this occurs by diffusion. External respiration is a process of breathing fresh air into the respiratory system, exchanging oxygen and carbon dioxide between the alveoli and the blood and the pulmonary capillaries. Adequate ventilation does not guarantee external respiration. Hemoglobin molecules pick up fresh oxygen as it crosses the alveolar membrane and transport it back to the left side of the heart. Internal respiration is exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells of the body. As the oxygenated blood travels through the arteries and capillaries, the oxygen passes from the blood and the capillaries to the tissue cells. In the presence of oxygen, the mitochondria of the cells convert glucose into energy using the process known as aerobic metabolism. Energy in the form of ATP is produced through the Krebs cycle and oxidative, phosphorylation. All right. Aerobic metabolism cannot meet the metabolic demands of the cell. Glycolysis results in less ATP production. Adequate levels of perfusion and external ventilation must be present for aerobic internal respiration. Anaerobic metabolism occurs when oxygen is not present. Understanding the process of ventilation, oxygenation, and respiration is an important concept for the advanced EMT. The goal is to deliver an adequate supply of oxygen to the cells of the body. Neural control. Neural control of breathing originates in the brain and brainstem. Primary control comes from the medulla and pons. Medullary respiratory centers control the rate, depth, and rhythm of breathing in a negative feedback interaction with the pons. The apneustic center of the pons is the secondary control center if the medulla fails to initiate respiration. Pneumotaxic center has an inhibitory influence on inspiration. Respiratory rate results from the interaction between the apneustic and the pneumotaxic centers. In times of increased demand, the pneumotaxic center decreases its influence. Chemical stimuli. The body has many receptors that monitor variables and provide feedback to the respiratory centers to modify the respiratory rate and depth. Chemoreceptors have important effects on respiratory rate and depth. Chemoreceptors constantly monitor the chemical composition of body fluids. Chemoreceptors that measure the amount of carbon dioxide in arterial blood are located in the carotid bodies of the aortic arch. Central chemoreceptors, which constantly monitor the pH of the CSF, are located adjacent to the respiratory centers in the medulla. An increase in the acidity of CSF triggers the central chemoreceptors to increase the rate and depth of respiration. Chemoreceptors located in the aortic arch and carotid bodies also respond to decreases in the PaO2, which is the backup to the primary control of ventilation. When serum carbon dioxide or hydrogen ion levels increase, chemoreceptors stimulate the dorsal and ventral respiratory groups in the medulla to increase the respiratory rates. The dorsal respiratory group is responsible for initiating inspiration based on the information received from the chemoreceptors. The ventral respiratory group is primarily responsible for motor control of the inspiratory and expiratory muscles. Pathophysiology of respiration. Disruption of pulmonary ventilation, oxygenation, and respiration will cause immediate effects on the body. Hypoxia. Tissues and cells of the body do not get enough oxygen. Patients with chronic obstructive pulmonary disease, COPD, have difficulty eliminating carbon dioxide through exhalation. Hypoxic drive stimulates breathing when the arterial oxygen level falls. Much less sensitive and less powerful than the carbon dioxide sensors in the brainstem, typically found in end-stage COPD. A high concentration of oxygen should never be withheld from any patient who needs it. Onset and degree of tissue damage caused by hypoxia often depend on the quality of ventilations. Early signs of hypoxia include restlessness, irritability, apprehension, fast heart rate or tachycardia, and anxiety. Late signs of hypoxia include mental status changes, a weak throaty pulse, and cyanosis. Responsive patients will report shortness of breath or dyspnea and may not be able to talk in complete sentences. Administer supplemental oxygen before signs and symptoms of hypoxia appear. Ventilation-perfusion ratio mismatch. To exchange gas by simple diffusion, ventilation and perfusion must be matched. A failure to match ventilation and perfusion contributes to most abnormalities in oxygen and carbon dioxide exchange. When ventilation is compromised but perfusion continues, blood passes over some alveolar membranes without gas exchange taking place. The result of inadequate perfusion is less oxygen absorption in the bloodstream and less carbon dioxide removal. Factors affecting ventilation. Maintaining a patent airway is critical. Many intrinsic and extrinsic factors cause airway obstruction. Interruptions to central and peripheral nervous systems have a drastic effect on the ability to breathe efficiently. Hypercapnia, overall increase of carbon dioxide levels in the bloodstream. Trauma to the head and spinal cord can also disrupt nervous control of ventilation. Muscular dystrophy causes degeneration of muscle fibers, slowing motor development and loss of muscle contractility. Patients with allergic reactions might also experience a decrease in pulmonary ventilation from bronchoconstriction. Extrinsic factors affecting pulmonary ventilation can include trauma and foreign body airway obstruction. Trauma to the airway or chest requires immediate evaluation and intervention. Blunt or penetrating trauma and burns can disrupt airflow through the trachea and into the lungs. The tongue is the most common airway obstruction in an unresponsive patient. This can result in hypoxia and hinder adequate tissue perfusion. Prompt correction is necessary. Respiratory splinting can result in decreased pulmonary ventilation. Hypoventilation is slow breathing. Carbon dioxide production exceeds the body's ability to eliminate it, or carbon dioxide elimination is depressed to the extent that it no longer keeps up with normal metabolism. Hyperventilation is rapid breathing. Carbon dioxide elimination exceeds carbon dioxide production. Hypoventilation and hyperventilation could represent the body's attempt to compensate for various abnormal conditions. Alkalosis is high blood pH. Acidosis is low blood pH. Decreases or increases in minute volume can result in problems with carbon dioxide levels in the blood. Refer to Table 11.3. Factors affecting oxygenation and respiration. Both oxygenation and perfusion need to function efficiently for proper respiration. External factors. External factors in the ambient air have a key role in the overall process of respiration. The attachment of carbon monoxide molecules to the hemoglobin molecules can cause false pulse oximeter readings. Internal factors. Conditions that reduce the surface area for gas exchange also decrease the body's oxygen supply. Medical conditions such as pneumonia, pulmonary edema, and COPD may also result in a disturbance of cellular metabolism. Non-functional alveoli inhibit the diffusion of oxygen and carbon dioxide. Intrapulmonary shunting. Blood enters the lungs from the right side of the heart, bypasses the alveoli, and returns to the left side of the heart in an unoxygenated state. Respirations increase or decrease based on the body's need at any given time. Pain and strong emotions can also increase respirations. Hypoxia increases respirations in an effort to bring in more oxygen. Respirations decrease as metabolism slows. Other conditions that affect the cells of the body include hypoxia, hypoglycemia, and infection. Without sufficient glucose, the cells will metabolize fatty acids, resulting in ketoacidosis. Circulatory compromise. For respirations to take place, the circulatory system must function efficiently. When this system becomes compromised, perfusion becomes inadequate. Obstruction of blood flow to individual cells and tissue is typically related to trauma emergencies. Conditions you may encounter include pulmonary embolism, simple or tension pneumothorax, open pneumothorax, hemothorax, or hemopneumothorax. Conditions such as heart failure and cardiac tamponade inhibit the ability of the heart to effectively pump oxygenated blood to the tissues. Hemorrhagic shock, a form of hypovolemic shock, is an abnormal decrease in blood volume. Vasodilatory shock is determined by the size of the blood vessels. As the diameter of the blood vessels increase, the blood pressure in the circulatory system decreases. Aggressively treat any patient suspected of being in shock to prevent further interruptions in tissue perfusion. Acid-base balance. Hypoventilation and hyperventilation along with hypoxia cause disruptions in the acid-base balance. This may result in rapid deterioration and death. Homeostasis is a tendency towards stability in the body's internal environment. Excess acid can be expelled as carbon dioxide from the lungs. Slowing respirations will increase the level of carbon dioxide. The fastest way the body can eliminate excess hydrogen ions is to create water and carbon dioxide. Anything that inhibits respiratory function can result in acid retention and acidosis. Acidosis can develop as a result of abnormal respiratory function such as bradypnea. Alkalosis can develop if the respiratory rate is too high, or tachypnea, or the volume is too great. The four main clinical presentations of acid-base disorders are respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Fluctuations in the pH due to the available bicarbonate level result in metabolic acidosis or alkalosis. Fluctuations in pH due to respiratory disorders result in respiratory acidosis or alkalosis. Treatment for the classic hyperventilation syndrome focuses on restoring the normal respiratory rate to increase the carbon dioxide level. Patient assessment, airway evaluation, recognizing adequate breathing. Breathing should appear easy, not labored. Normal respirations, refer to Table 11.4, are 12 to 20 breaths a minute, adequate depth or tidal volume, regular pattern of inhalation and exhalation, and clear and equal bilateral breath sounds. Recognizing inadequate breathing. An adult patient who is breathing at a rate of fewer than 12 breaths a minute or more than 20 breaths a minute should be evaluated for other signs of inadequate breathing. Patients with respiratory disease often compensate with preferential positioning. Respiratory distress may be the result of upper and or lower airway obstruction, inadequate ventilation, impairment of the respiratory muscles, or impairment of the nervous system. Any difficulty in respiratory rate, regularity, or effort is defined as dyspnea. Dyspnea may be the result of or result in hypoxemia. Untreated hypoxia will result in anoxia and death of the body cells and tissues. Recognition and treatment of dyspnea are crucial to patient survival. Treatment of the patient will be ineffective if the airway is not patent and the patient is not breathing adequately. Evaluation of the patient in respiratory distress includes observations, palpation, and auscultation. When you assess a patient with respiratory distress, how is the patient positioned? Is he or she in a tripod position with elbows out? Is the patient experiencing orthopnea? Is there adequate rise and fall of the chest? Is the patient gasping? What is the color of the skin? Is the skin moist or clammy? And is there flaring of the nares present? Is the patient breathing through pursed lips? Do you note any retractions? Is the patient using accessory muscles to breathe? Is the patient's chest wall moving symmetrically? Is the patient taking a series of quick breaths followed by a prolonged exhalation phase? Patients with inadequate breathing may appear to be working hard to breathe, having labored breathing. Accessory muscles are not used during normal breathing. Signs of inadequate breathing in adults are respiratory rate fewer than 12 or greater than 20, irregular rhythm, such as a patient taking a series of deep breaths followed by a period of apnea, diminished, absent, or noisy auscultated breath sounds, abdominal breathing, reduced flow of expired air at the nose and mouth, unequal or inadequate chest expansion resulting in reduced tidal volume. Increased effort of breathing, shallow breath, reduced tidal volume, skin that is pale, cyanotic, blue, cool, mottled, or moist, retractions, or staccato speech patterns. Pay particular attention to the external environment. Auscultate breathing with and without a stethoscope. Feel for air movement at the mouth and nose. Observe the chest for symmetry and note any paradoxical motion. Evaluate for pulsus paradoxus, and a history of the present illness is a vital part of your assessment. Note protective reflexes of the airway. Sneezing clears the nasopharynx and is often caused by an irritant such as dust. Sighing and hiccuping are other modified forms of respiration. Table 11.5 shows various respiratory patterns and causes. Serious head injuries may also cause changes in the normal respiratory rate and pattern of breathing. The result may be irregular, ineffective respirations that may or may not have an identifiable pattern. These are ataxic respirations. A patient may appear to take a breath after his or her heart has stopped. These are agonal gasps. Be vigilant when monitoring patients in respiratory distress. Patients with inadequate breathing have inadequate minute volume and need to be treated immediately. Emergency medical care includes airway management, supplemental oxygen, and ventilatory support. Assessment of respiration. A patient's level of consciousness, or LOC, and skin color are excellent indicators of respiration. When treating patients with an altered mental status, always consider the possibility that the patients may not be getting adequate oxygen to the brain. Determine a baseline mental status on the patient. As oxygen fails to reach the skin from a lack of perfusion, color in the skin changes to reflect the inadequate oxygenation. Pale skin and mucous membranes are associated with poor perfusion caused by illness or shock. Consider proper oxygenation when assessing patients. Several methods can be used to assess proper oxygenation. Pulse oximetry. It is a simple, rapid, safe, and non-invasive method of measuring how well a person's hemoglobin is saturated. Routine vital sign that can be used as part of any patient assessment, and a pulse oximeter measures the percentage of hemoglobin in the arterial blood that is saturated with oxygen. To ensure that the instrument is measuring arterial and not venous oxygen saturation, SpO2, pulse oximeters are designed to assess only pulsating blood vessels. The functionality can be checked by comparing the pulse reading with the measurement obtained by palpation. Situations in which pulse oximeters may be useful in pre-hospital emergency medical care include the following: monitoring the oxygenation status of a patient during an attempt to insert an advanced airway or during suctioning, identifying deterioration in the condition of a trauma patient, identifying deterioration in the condition of a patient with cardiac disease, identifying high-risk patients with respiratory conditions, and assessing vascular status in orthopedic trauma. Be aware of circumstances that might produce erroneous readings. This is bright ambient light, patient motion, poor perfusion, nail polish, venous pulsations, and abnormal hemoglobin. Do not make treatment decisions based solely on pulse oximetry. Peak expiratory flow measurement. Bronchoconstriction can be evaluated by measuring the peak rate of a forceful exhalation with a peak expiratory flow meter. Increasing peak expiratory flow suggests that the patient is responding to treatment. Decreasing peak expiratory flow may be an indication of deterioration. Peak expiratory flow varies based on sex, height, and age. Perform the test 3 times and take the best peak flow rate of the 3 readings. Arterial blood gas analysis. This rely on non-invasive methods of assessing ventilation and oxygenation. Analysis of arterial blood gases, or ABGs, provides the most comprehensive quantitative information about the respiratory system. Normal ABG values are summarized in Table 11.6. To maintain normal ABG values, a balance between alveolar volume and perfusion of the alveolar capillaries must be maintained. End-tidal carbon dioxide assessment. End-tidal CO2, or EtCO2, monitor detects the presence of carbon dioxide in exhaled air. The types of monitors include colorimetric, digital, and digital/waveform. A colorimetric carbon dioxide detector provides qualitative information regarding the presence of carbon dioxide in the patient's exhaled breath. This might give a false positive reading if the patient has carbon dioxide trapped in the stomach from the ingestion of carbonated beverages. It is sensitive to extremes of temperature and humidity and is less reliable if vomitus or other secretions get inside of it. A capnometer provides quantitative information in real time by displaying a numeric reading of exhaled carbon dioxide levels. A capnometer provides quantitative information in real time, we just said that, by displaying a numeric reading of exhaled carbon dioxide levels. A capnographer is a device that provides a graphic representation of exhaled carbon dioxide levels. Waveform capnography provides quantitative, real-time information regarding the patient's exhaled carbon dioxide level. Quantitative waveform capnography is the recommended method of monitoring initial and ongoing placement of an advanced airway device. Capnography can also serve as an indicator of the effectiveness of chest compressions and to detect return of spontaneous circulation, or ROSC. Use of EtCO2 monitoring is limited with patients in cardiac arrest. Opening the airway. Emergency medical care begins with ensuring an open airway. To open the airway and assess breathing, the patient needs to be in the supine position. To position an unresponsive patient, follow the steps in Skill Drill 11.1. The head tilt chin lift maneuver for patients who have not sustained trauma. This is sometimes all that is needed for the patient to resume breathing. To perform the head tilt chin lift maneuver, follow these steps. With the patient in a supine position, position yourself beside the patient's head. Place the heel of one hand on the patient's forehead and apply firm backward pressure with your palm to tilt the patient's head back. Place the fingertips of your other hand under the patient's chin. Lift the chin upward, bringing the entire lower jaw with it and helping to tilt the head back. Lift so that the teeth are nearly brought together, but avoid closing the mouth completely. Continue to hold the forehead to maintain the backward tilt of the head. The jaw thrust maneuver. Use this method if a cervical spine injury is suspected. Perform the jaw thrust maneuver on an adult in the following manner. Kneel above the patient's head, place fingers behind the angles of the lower jaw, and move the jaw upward. Use your thumbs to help position the lower jaw to allow breathing through the mouth and nose. The completed maneuver should open the airway with the mouth slightly open and the jaw jutting forward. The tongue jaw lift maneuver. This is used to open the airway for oropharyngeal suctioning. It cannot be used to ventilate a patient because it does not allow for an adequate mask seal. To perform the tongue jaw lift maneuver, follow these steps. Position yourself at the patient's side. Place the hand closest to the patient's head on the forehead. With your other hand, reach into the patient's mouth and hook your first knuckle under the incisors or the gum line. While holding the patient's head and maintaining the hand on the forehead, lift the jaw straight up. Maintaining the airway. Place the patient in the recovery position if he or she is breathing on his or her own at a normal rate and with adequate tidal volume. This does not include patients that have a traumatic injury. Take the following steps to put the patient in the recovery position. Roll the patient onto the side so that the head, shoulders, and torso move at the same time without twisting. Place the patient's lower arm and upper hand under his or her cheek. After patients have resumed spontaneous breathing after being resuscitated, the recovery position will prevent the aspiration of vomitus. Suctioning. The airway must be kept clear to ventilate the patient properly. If the airway is not clear, material can be forced into the lungs. This can cause a complete airway obstruction. Suctioning is the first priority. If you hear gurgling, the patient needs suctioning. Suctioning equipment: portable, hand-operated, battery-operated, and fixed or mounted types. Pause. Also, under suctioning equipment is portable suctioning unit, and it provides enough vacuum pressure and flow to suction the mouth and the oropharynx. A portable and fixed suctioning unit should be fitted with a wide-bore, thick-walled, non-kinking tube, soft and rigid suction catheters, a non-breakable disposable collection bottle, and a supply for water for rinsing the tips. The suction catheter is a hollow cylindrical, I just said it and I can't say it again, cylindrical device used to remove fluids and secretions from the airway. A tonsil tip catheter is best for sectioning the pharynx. Tips with curved contours allow for easy, rapid placement. Soft plastic, non-rigid catheters, sometimes called French or whistle tip catheters, can be used in the back of the mouth and in patients with a stoma. Always measure for proper size before inserting any catheter. Never insert a catheter past the base of the tongue. Techniques of suctioning. Inspect your suctioning equipment regularly. Follow these steps to operate the suction unit. Check the unit for proper assembly of all of its parts. Turn on the suctioning unit and test it to ensure a vacuum pressure of more than 300 millimeters of mercury. Select and attach the appropriate catheter to the tubing. Limit suctioning time to no more than 15 seconds at one time for adults, 10 seconds for children, and 5 seconds for infants. Suctioning removes oxygen from the airway along with the obstructive material. To properly suction a patient's airway, follow the steps in Skill Drill 11-2. Only attempt to remove an object if it is visible during examination of the open mouth. Continuous ventilation is not appropriate if vomitus or other particles are present in the airway. Clean and decontaminate your suctioning equipment after each use according to the manufacturer's guidelines. Tracheobronchial suctioning of an intubated patient. Endotracheal ET intubation is a paramedic skill. Following intubation, fluids may occlude the ET tube. Advanced EMT may assist with tracheobronchial suctioning of an intubated patient. Pass the suction catheter into the ET tube. Pre-oxygenation is essential before tracheobronchial suctioning. Apply suction as the catheter is extracted. Continue to ventilate and oxygenate the patient. Basic airway adjuncts prevent obstruction of upper airway by the tongue and allow passage of air and oxygen to the lungs. Oropharyngeal airway prevents the tongue from obstructing the glottis, often used in conjunction with bag mask ventilation, BVM. Indications for an oral airway include unresponsive patients without a gag reflex, any patient being ventilated with a bag mask device without a gag reflex. Contraindications for the oral airway include responsive patients or any patient who has an intact gag reflex. Gag reflex is a productive reflex mechanism that prevents food and other particles from entering the airway. Clearly understand when and how this device is used. If the oropharyngeal airway is not the proper size or is inserted incorrectly, it could block the airway. Follow the steps in Skill Drill 11.3 to insert an OPA. Take care to avoid injuring the hard palate as you insert the airway. Follow the steps in Skill Drill 11.4 to insert an oral airway with a 90-degree rotation. These are NPAs, or nasopharyngeal airways, used in patients with intact gag reflex or who is unstable to maintain an airway. Patients who may also benefit are altered mental status or someone who just had a seizure. Use extreme care in trauma cases. Insertion through a basilar skull fracture can penetrate into the brain. This type of airway is usually better tolerated by patients who have an intact gag reflex. Slight bleeding may occur even when the airway is inserted properly. Indications for the NPA include patients with an altered mental status who still have an intact gag reflex, patients who otherwise will not tolerate an OPA. Contraindications are severe head injury with blood draining from the nose, potential for a basilar skull fracture, history of fractured nasal bone, or meeting with resistance during insertion. Follow steps in Skill Drill 11.5 to ensure correct placement of the NPA. Supplemental oxygen administered to any patient with potential hypoxia, even if the patient's clinical appearance is otherwise normal. It reduces pain and further damage. If you are in doubt as to the patient's oxygenation status, administer supplemental oxygen. Oxygen delivery method must be reassessed frequently and adjusted accordingly. Never withhold oxygen from a patient who might benefit from it. Supplemental oxygen equipment is oxygen cylinders. Newer cylinders are often made of lightweight aluminum or spun steel. Check that the cylinder is labeled for medical oxygen. Of particular importance are the month, and year stamps. Table 11.7 lists the oxygen cylinder sizes carried on ambulances. The length of time you can use an oxygen cylinder depends on the pressure in the cylinder and the flow rate. A method of calculating cylinder duration or tank life is shown in Table 11.8. Liquid oxygen is oxygen that is cooled to an aquatic or aqueous state. It converts to the gaseous state when warmed, becoming more commonly used as an alternative to compressed gas oxygen. Its much larger volume of oxygen can be stored in a liquid state. Containers do not need to be filled as often. It weighs less than aluminum or steel tanks, requires upright storage, and have special requirements for filling, large volume storage, and cylinder transfer. Safety considerations as contents are under pressure. Ensure that the correct pressure regulator is firmly attached before transport. A puncture or hole in the tank can cause the cylinder to become a deadly missile. Do not handle a cylinder by the neck assembly alone. Cylinders should be secured with mounting brackets, and contact with the liquid oxygen should be prevented at all costs. That sounds dangerous. Pin indexing system. The compressed gas industry has a system for portable cylinders to prevent an oxygen regulator from being connected to a carbon dioxide cylinder. This features a series of pins on a yoke that must be matched with the holes on the valve system of the gas cylinder. The arrangement of pins and holes varies for different gases according to accepted national standards. Each cylinder of a specific gas has a given pattern and a given number of pins. These safety measures make it impossible for you to attach a cylinder of nitrous oxide to an oxygen regulator. The safety system for large cylinders is known as the American Standard System. Pressure regulators. Pressure of gas in a full oxygen cylinder is approximately 2,000 psi. Regulators reduce the pressure to a more useful range, usually 40 to 70 psi. Most pressure regulators reduce the pressure in a single stage. A two-stage regulator will reduce the pressure first to 700 psi and then to 40 to 70 psi. Final attachment for delivering the gas to the patient is usually a quick connect female fitting that will accept a quick connect male plug from a pressure hose or ventilator or resuscitator, or a flow meter that will permit the regulated release of gas measured in liters per minute. Flow meters are permanently attached to pressure regulators on emergency medical equipment. Two types are commonly used. Pressure compensated flow meter, a float ball within a tapered calibrated tube. Float rises or falls according to the gas flow within the tube. It is affected by gravity. A Borden gauge flow meter is not affected by gravity. Pressure gauge is calibrated to record the flow rate. Operating procedures to place an oxygen cylinder into service follow the steps in Skill Drill 11.6. Open flow meter to the desired flow rate. You must be completely familiar with the equipment before attempting to use it on a patient. Confirm flow of the device. Apply the oxygen device to the patient and make any necessary adjustments. Monitor the patient's reaction to the oxygen and to the oxygen device. Disconnect the tubing from the flow meter nipple and turn off the cylinder valve when oxygen therapy is complete. After turning off the flow meter, the gauge on the regulator should read 0 with the tank valve closed. Hazards of supplemental oxygen. Oxygen supports combustion. Keep any possible source of fire away from the area while oxygen is in use. Be extremely cautious with any enclosed environment in which oxygen is being administered. Never leave an oxygen cylinder standing unattended. Oxygen toxicity. Excessive supplemental oxygen can have a detrimental effect on patients with certain illnesses. Oxygen toxicity is damage to cellular tissue as a result of excessive oxygen levels in the blood. Current evidence suggests that increased cellular oxygen levels contribute to the production of oxygen-free radicals. Tailor oxygen therapy to patient needs and use caution with administration. Oxygen delivery devices. Oxygen delivery equipment that is used in the field should be limited to non-rebreathing mask, a bag mask device, and nasal cannulas. Non-rebreathing mask is the preferred device in the pre-hospital setting. Contraindications include apnea and poor respiratory effort, delivers oxygen passively, requires adequate tidal volume for oxygen to be effectively drawn into the lungs. Combination mask and reservoir bag system. Oxygen fills a reservoir bag attached to the mask by a one-way valve. Exhaled gas escapes through the flapper valve side ports covered by a one-way disc at the cheek areas of the mask. The valve between the mask and the reservoir prevents the patient from rebreathing exhaled gases. Ensure that the reservoir bag is full before the mask is placed on the patient. Adjust the flow rate so that the bag does not fully collapse when the patient inhales. Leaving the mask in place while oxygen is not flowing allows the patient to rebreathe exhaled carbon dioxide. Use a pediatric mask for infants and children. Nasal cannulas deliver oxygen through two small tube-like prongs that fit into the patient's nostrils. Limited use in pre-hospital setting, ineffective for patients with poor respiratory effort, severe hypoxia, apnea, or mouth breathing. This is used for patients requiring long-term oxygen therapy for certain diseases such as COPD, whose current complaint is unrelated to the respiratory disease. This is mainly used for the patient who will not tolerate a non-rebreathing mask. Well tolerated even by patients who are claustrophobic, does not deliver high volumes or high concentrations of oxygen, delivers dry oxygen directly into the nostrils. Consider using humidification for long transports. A partial rebreathing mask. This is similar to a non-rebreathing mask, except where there is no one-way valve between the mask and reservoir. Patients rebreathe a small amount of their exhaled air. This is ideal for patients experiencing hyperventilation syndrome. Venturi mask has a number of attachments to vary the percentage of oxygen delivered while a constant flow is maintained. Air is drawn into the flow of oxygen as it passes a hole in the line. Medium flow device that delivers 24% to 40% oxygen depending on the manufacturer. The advantage is the fine adjustment capabilities for long-term management of patients in physiologically stable condition. Such fine adjustments are unnecessary in the emergency setting. The tracheostomy mask. A patient with a tracheostomy does not breathe through the mouth and nose. A face mask or nasal cannula cannot be used. Specifically designed tracheostomy masks cover the tracheostomy hole, have a strap that goes around the neck. If you do not have a tracheostomy mask, you can improvise by placing a face mask over the stoma. Even though the mask is shaped to fit the face, you can usually get an adequate fit over the patient's neck by adjusting the strap. Oxygen humidifiers. This is used by some EMS systems, usually indicated only for long-term oxygen therapy. A sterile water reservoir is needed for humidifying the oxygen. Refer to local protocols for guidance involving patient treatment issues. Assisted and artificial ventilation. A patient who is not breathing needs artificial ventilation and 100% supplemental oxygen. Assisted and artificial ventilation are probably the most important skills in EMS. Basic airway and ventilation techniques are extremely effective when administered appropriately. An irregular breathing pattern will also require artificial ventilation. Fast, shallow breathing moves air primarily in the larger airway passages and does not allow for adequate exchange of air and carbon dioxide in the alveoli. Signs of altered mental status and inadequate minute volume are indications for assisted ventilation. Excessive accessory muscle use and fatigue from labored breathing are signs of potential respiratory failure. Two treatment options for patients in severe respiratory distress or respiratory failure are assisted ventilation and continuous positive airway pressure, or CPAP. Follow these steps to assist the patient with ventilations using a bag mask device. Explain the procedure to the patient. Place the mask over the patient's nose and mouth. Squeeze the bag each time the patient breathes. After the initial 5 to 10 breaths, slowly adjust the rate and deliver an appropriate tidal volume. Adjust the rate and tidal volume to maintain an adequate minute volume. Artificial ventilation. Begin artificial ventilation immediately once you determine a patient is not breathing. Normal ventilation versus positive pressure ventilation. Artificial ventilations are not the same as normal breathing. During normal ventilation, the diaphragm contracts and negative pressure in the chest cavity sucks air into the chest. Positive pressure ventilation generated by a device forces air into the chest cavity from the external environment. Refer to Table 1110 for the differences. Positive pressure ventilation causes the walls of the chest cavity to push out of their normal anatomic shape. There is an increase in overall intrathoracic pressure within the chest cavity. Venous blood flow is decreased due to the increased pressure in the chest. Advanced EMTs must regulate the rate and volume of artificial ventilations to avoid over-distension of the chest wall. The force generated from the positive pressure ventilation allows air to enter not only the trachea but also the esophagus, and this is a potential risk of gastric distension. Mouth-to-mouth and mouth-to-mask ventilation. Mouth-to-mouth ventilation is routinely performed with a barrier device, protective plastic barrier placed on the patient's face with a one-way valve. Mouth-to-mouth is the most basic form of ventilation. It includes risk of unknown communicable diseases and psychological barriers. Mouth-to-mask ventilation is preferred. It places a physical barrier between the rescuer's mouth and the patient's mouth. Most masks offer a one-way valve to prevent exposure to blood and body fluids. It is also easier to secure an effective seal with a mask. A mask with an oxygen inlet provides oxygen during mouth-to-mask ventilation to supplement the air from your own lungs. Follow steps in Skill Drill 11.7 to use mouth-to-mask ventilation. Make sure that you are providing the correct number of breaths per minute for the patient's age. To increase the oxygen concentration, administer high-flow oxygen at 15 liters a minute through the oxygen inlet valve of the mask. A bag mask device can deliver nearly 100% oxygen. It can deliver only as much volume as you can squeeze out of the bag by hand. It provides less tidal volume than mouth-to-mask ventilation but higher oxygen concentration. This is the most common method used in the field. It is a difficult skill to master. It takes 2 rescuers to use a bag mask device on a trauma patient unless an advanced airway has already been inserted. Practice on ventilation mannequins several times before using a bag mask device on the patient. Most effective when used with supplemental oxygen in a reservoir. Depending on patient's LOC, you should use an oral or nasal airway adjunct in conjunction. You should not use this on any patient who is intolerant of its use. If the patient is responsive and breathing inadequately, ventilatory assistance with a bag mask device will be required to maintain adequate minute volume. Bag mask device components. All adult bag mask devices should have a disposable self-refilling bag, no pop-off valve, or if one is present, the capability of disabling the pop-off valve, an outlet valve that is a true valve for normal breathing, an oxygen reservoir that permits delivery of a high concentration of oxygen, a one-way no-jam inlet valve system, a transparent face mask, and the ability to perform under extreme environmental conditions. The volume of air or oxygen to deliver to the patient is based on visible chest rise. A delivered total tidal volume of 500 to 600 milliliters or 6 to 7 milliliters per kilogram per breath will produce visible chest rise in most adults. Breaths that are delivered too forcefully or too fast can result in gastric distension and decreased blood return to the heart. Bag mask device technique. Ventilation using a bag mask device is a challenging skill. Performance depends on having enough personnel to carry out other actions that need to be done at the same time. Whenever possible, work with a partner. 3 major considerations when using a bag mask device to ventilate a patient. Typical adult bag mask device holds a much larger volume of air than is needed. Quick, forceful delivery of breaths may result in gastric distension, as it only takes a small amount of pressure to override the lower esophageal sphincter. And be cautious of the rate of delivery of breaths. Follow these steps to use the 2-person bag mask device technique. Kneel above the patient's head. Maintain the patient's neck in a hyperextended position unless you suspect a cervical spine injury. Connect the bag mask device to supplemental oxygen. Open the patient's mouth and suction as needed. Insert an oral or nasal airway. Place the mask on the patient's face. Ensure the top is over the bridge. Okay, ensure the top is over the bridge of the nose and the bottom is in the groove between the lower lip and the chin. Bring the lower jaw up to the mask with your last 3 fingers. Hold the mask in place while your partner squeezes the bag with 2 hands until the patient's chest visibly rises. If you are alone, place your thumb and index finger as high up on the mask as you can to form a C. Maintain the airway by lifting the bony prominence of the chin with your remaining fingers to form an E. This is the EC clamp method. Observe for gastric distension, changes in compliance of the bag with ventilations, and improvement or deterioration of the patient's condition. When using the bag mask device to assist ventilation, squeeze the bag as the patient breathes in. For the next 5 to 10 breaths, slowly adjust the rate and deliver tidal volume until the adequate minute volume is reached. Ventilation is not adequate if the patient's chest does not rise and fall with each ventilation, the rate of ventilation is too slow or too fast for the patient's age, or the heart rate does not return to normal. If the patient's stomach, rather than the chest, seems to be rising and falling, you should reposition the head. Advanced airway techniques are beneficial when ventilation with basic means is not effective, the patient has a cervical spine injury, or the patient condition warrants. Manually triggered ventilations or MTV devices. Flow-restricted oxygen-powered ventilation devices used to ventilate apneic or hypoventilating patients. It can also be used to provide supplemental oxygen to breathing patients. They have a demand valve triggered by the negative pressure generated by inhalation, deliver almost 100% oxygen, allow a single rescuer to use both hands to maintain a mask-to-face seal, reduce rescuer fatigue associated with using a bag mask device on extended transports, associated with difficulty in maintaining adequate ventilation without assistance, should not be used routinely. A special unit and additional training are required. It's virtually impossible to assess for lung compliance. The amount of pressure necessary to ventilate a patient adequately will vary according to the size of the patient. Pressures that are too great can cause a pneumothorax. Automatic transport ventilators or resuscitators. This allows variables of ventilation to be precisely set: the ventilator rate, tidal volume, peak inspiratory time. Steps for using the ATV are as follows. Attach the ATV to the wall-mounted oxygen source. Set the ventilator rate, tidal volume, and peak inspiratory time on the ATV as appropriate for the patient's condition. Connect the ATV to the 15-22 mm fitting of the ET tube or other advanced airway device. Auscultate the patient's breath sounds and observe for equal chest rise to ensure adequate ventilation. Free your hands to perform other tasks. Have a bag mask, device, and mask ready if ATV malfunctions. Most models have adjustments for respiratory rate and tidal volume. In most cases, the respiratory rate is set at the midpoint or average for the patient's age. The tidal volume can be adjusted based on the patient's chest rise and physiologic response. ATVs are considered volume cycled, rate controlled ventilators. Set at a fixed rate and will not cycle in conjunction with the timing of chest compressions. Oxygen powered, although some models may require an external power source. It has a pressure relief valve, which can result in hypoventilation in patients with poor lung compliance, increased airway resistance, or airway obstruction. Lung compliance is the ability of the alveoli to expand when air is drawn in during inhalation. Possibility of relief valve failing or of overzealous ventilation. Continuous positive airway pressure, or CPAP, non-invasive means of providing ventilatory support for patients in respiratory distress, used at night by people with obstructive sleep apnea. Early intervention with CPAP is an alternative means for providing ventilatory assistance. It can prevent the need for ET intubation. It's becoming widely used by EMS. CPAP increases pressure in the lungs, opens collapsed alveoli, pushes more oxygen across the alveolar membrane, and forces interstitial fluid back into pulmonary circulation. The desired effect of CPAP is to improve pulmonary compliance and make spontaneous ventilation easier. A good seal with minimal leak between the face and mask is essential. Indications for CPAP. This is indicated for patients experiencing respiratory distress in which their own compensatory mechanisms cannot keep up with their oxygen demand. General guidelines for CPAP candidates. Patient is alert and able to follow commands. Obvious signs of moderate to severe respiratory distress. Respiratory distress after a submersion incident. Rapid breathing, more than 26 breaths a minute, or pulse oximetry reading of less than 90%. Contraindications. General contraindications for CPAP use is a patient is unresponsive or otherwise unable to follow verbal commands, respiratory arrest or agonal respirations, patient is unable to speak, patient is unable to protect his or her own airway, hypoventilation, hypotension, signs and symptoms of a pneumothorax or chest trauma, closed head injury, facial trauma, cardiogenic shock. Tracheostomy, active gastrointestinal bleeding, nausea or vomiting, history of recent gastrointestinal surgical procedure, patient is unable to sit up, inability to properly fit the CPAP system mask and strap, excessive facial hair or dysmorphic facial features, patient cannot tolerate the mask. Always reassess the patient for signs of deterioration and or respiratory failure. Application of CPAP. Several varieties of CPAP units are available to EMS services. CPAP units are generally composed of a generator, a mask, a circuit that contains corrugated tubing, a bacteria filter, and a one-way valve. Patient exhales against a resistance called positive end expiratory pressure, or PEEP. PEEP maintains pressure in the lungs at the end of exhalation and keeps the open alveoli from collapsing. Some CPAP models have PEEP valves that connect separately. PEEP is controlled by manually adjusting the PEEP using a manometer or predetermined by a fixed setting on the PEEP valve. Most CPAP units are powered by oxygen. Proper planning for oxygen consumption is necessary. Follow the steps in Skill Drill 11.8 to use a CPAP. Complications of CPAP. Some patients find CPAP claustrophobic. Do not force the mask on patients. Coach patients through CPAP application. It's possible to cause a pneumothorax as a result of barotrauma. Increased pressure in the chest cavity can result in hypotension. Special considerations: gastric distension, inflation of the patient's stomach with air, likely to occur if excessive pressure is used to inflate the lungs, promotes regurgitation of stomach contents, which creates the potential for aspiration. A distended stomach pushes the diaphragm upward into the chest. Signs of gastric distension include increase in the diameter of the stomach, increasingly distended abdomen, and increased resistance to bag mask ventilations. Laryngectomy, tracheostomy, stoma, and tracheostomy tubes. Laryngectomy is a surgical procedure in which the larynx is removed. This is performed by making a tracheostomy, thus creating a stoma. Surgical removal of the entire larynx is called total laryngectomy. A partial laryngectomy entails surgical removal of a portion of the larynx. Artificial ventilation through the nose and mouth may still be effective after a partial laryngectomy. Sectioning of the stoma. Failure to recognize and identify the need for sectioning could result in hypoxia. You must perform sectioning of the patient's stoma with extreme care. Even the slightest irritation of the tracheal wall can result in a violent laryngospasm. Limit sectioning of the stoma to 10 seconds at a time. The steps for sectioning a stoma are shown in Skill Drill 11.9. Ventilation of stoma patients. Perform ventilation using a mouth-to-stoma technique or with a bag mask device. You should use an infant or child-sized mask to make an adequate seal over the stoma. 2 rescuers are needed to perform the bag mask device to stoma ventilation. This technique would only work if the patient had a partial laryngectomy. If the stoma is sealed during ventilation, the ability to artificially ventilate the patient may be improved. The steps for performing mouth-to-stoma ventilation with a resuscitation mask are shown in Skill Drill 11.10. The steps for performing bag mask device to stoma ventilation are shown in Skill Drill 11.11. Tracheostomy tubes are plastic tubes placed within the tracheostomy site or stoma. This requires a 15 at 22nd millimeter adapter to be compatible with ventilatory devices. Ventilation is accomplished by simply attaching the bag mask device to the 15 millimeter adapter on the tracheostomy tube. When a tracheostomy tube becomes dislodged, stenosis or narrowing of the stoma may occur. The patient may be less tolerant of even brief periods of hypoxia. Dental appliances. Many dental appliances can cause an airway obstruction. Loose dental appliances should be manually removed before providing ventilation. Providing bag mask device or mouth-to-mask ventilation is usually Providing bag mask device or mouth-to-mask ventilation is usually much easier when dentures can be left in place. Periodically reassess the patient's airway to make sure the devices are firmly in place. Facial bleeding. Airway problems can be especially challenging in patients with serious facial injuries. Control bleeding with direct pressure and suction is necessary. Facial injuries are also associated with a high suspicion for cervical spine injury. When inserting any type of airway device, it is imperative to maintain inline stabilization of the cervical spine. Supraglottic airway devices. The King LT airway is latex-free, single-use, single-lumen airway that is blindly inserted into the esophagus. It can be used to provide positive pressure ventilations to apneic patients. Helps maintain a patent airway in unresponsive patients who are breathing spontaneously. The device consists of a curved tube with ventilation ports located between 2 inflatable cuffs. Openings located between these 2 cuffs can provide ventilation of the lungs after positioning is confirmed. It can be used as a rescue airway device. Two types of King LT airways are available, the King LTD and the King LTSD. The King LTSD is a more commonly used device, available in 7 sizes. Refer to Table 1112 for those. The distal end of the King LTD is closed, whereas the distal end of the King LTSD is open. Indications and contraindications for the King LT airway. Alternative to bag mask ventilation when a rescue device is required for a failed intubation attempt. Contraindications: does not protect the airway from effects of vomiting and aspiration and should not be used in patients with an intact gag reflex. Complications of the King LT airway: laryngospasm, vomiting, and possible hypoventilation may occur. Trauma may also result from improper insertion technique. Ventilation may be difficult if the pharyngeal balloon pushes the epiglottis over the glottic opening. Insertion technique: patient's height and weight will determine the size of the airway. The steps for inserting the King LT airway are shown in Skill Drill 1112. Alright, the laryngeal mask airway, or LMA, provides a feasible option for cases that require more airway support than mask ventilation but do not require intubation. Designed to provide a conduit from the glottic opening to the ventilation device. Opening of the LMA is positioned right at the glottic opening. Many advantages compared with ventilating the unprotected airway with a mask. It provides better oxygenation. Ventilation does not require the continual maintenance of a mask seal. Insertion is easier. Less risk of soft tissue, vocal cord, tracheal wall, and dental trauma. Provides protection from upper airway secretions. It does not provide as much protection against aspiration as does endotracheal intubation. It may actually increase the risk of aspiration if the patient regurgitates. This should not be considered a primary airway for emergency patients. Indications and contraindications. Okay. Indications and contraindications for the LMA. It should be considered only when the patient cannot be intubated, less effective in obese patients, and should not be used in patients with morbid obesity. It is ineffective for the ventilation of patients requiring high pulmonary pressures. Complications of using the LMA: regurgitation and subsequent aspiration. LMA should be used only in patients who are fasting. Hypoventilation of patients who require high ventilatory pressures can occur. Patients should be monitored for evidence of upper airway swelling. Equipment for the LMA comes in 7 sizes based on the patient's weight. Consists of a tube and the mask or inflatable cuff. The cuff provides a collar designed to position the opening of the tube at the glottic opening when inflated. 2 vertical bars are present at the opening of the tube. The cuff has a one-way valve assembly and should be inflated with a predetermined volume of air. Insertion technique. The steps for using an LMA are summarized in Skill Drill 1113. Continuously and carefully monitor for regurgitation in the tube. Carefully attend to the airway during any patient movement. iGel. The iGel supraglottic airway is inserted in a manner similar to the LMA. It is designed to create a non-inflatable anatomic seal of the pharyngeal, laryngeal, and perilaryngeal structures. The common rescue airway device. It features an integral bite block, a gastric access channel, a supplemental oxygen inlet port, and a support strap. A color-coded proximal hook ring indicates the size of the iGel. Table 1113 lists 3 adult-sized iGel supraglottic airways and patient weight criteria. The steps for inserting an iGel supraglottic airway are shown in Skill Drill 1114. The Cobra perilaryngeal airway, or Cobra PLA, is the distal part of the airway is cobra-shaped. a supraglottic device with a tube for ventilation and a circumferential cuff proximal to the distal end. It's possible to successfully place the device with minimal or no experience. Available in 8 sizes. Proper size is the one that comfortably fits through the patient's mouth. Indications and contraindications for the Cobra PLA. I may not have said that right on the last slide, but we're going to get through it because it's like 1:15 in the morning. So it's recommended for use only in patients who are not at risk of vomiting. Contraindications include risk for aspiration and massive trauma to the oral cavity. Complications of the Cobra PLA. If the Cobra is not inserted far enough, inflation of the cuff may cause the tongue to protrude from the mouth, disrupting an adequate seal. Using the proper size is vital. Insertion technique. Fully deflate the cuff and apply a water-soluble gel to the front and back of the device and to the cuff. Open the airway with a tongue-jaw lift maneuver and direct the distal end of the Cobra PLA straight back between the tongue and the hard palate. Inflate the cuff with only enough air to achieve a good seal. Ventilate the patient while observing for chest rise and auscultating over the neck, chest, and epigastrium. Use a detection device for further confirmation and secure the device in place. Multi-lumen airway device, combi tube, can be inserted blindly into the airway. Reasonable alternative to ET intubation. Proven to secure the airway and allow for better ventilation than a bag mask device. The tube can be used for ventilation, whether it is inserted into the esophagus or trachea, contains 2 lumens, accommodates any ventilation device. Effective ventilation is possible whether the tube enters the esophagus or the trachea. A jaw thrust maneuver should easily alleviate any ventilatory difficulty that occurs if the epiglottis partially obstructs the airway. It requires strict attention and good assessment skills. Multi-lumen airways are usually considered temporary airways and should be replaced as soon as possible. Indications and contraindications for the combi tube. Indicated for the airway management of unresponsive apneic patients with no gag reflex in whom AT intubation is not possible or has failed. It cannot be used in pediatric patients younger than 16 years. It should be used only for patients between 5 and 7 feet. Should not be used in patients with a known pathologic condition of the esophagus. Complications of the combi tube. Unrecognized displacement of the tube into the esophagus. Use a rigorous confirmation protocol following insertion of the device. Laryngospasm, vomiting, and possible hypoventilation may occur during insertion. Trauma to the pharynx or esophagus may also result from improper insertion techniques. Ventilation may be difficult if the pharyngeal balloon pushes the epiglottis over the glottic opening. Insertion techniques. Check and prepare all equipment. Check both cuffs to ensure that they hold air. For insertion, the patient's head should be placed in the neutral position. Forwardly displace the jaw. Insert the device. Inflate the cuffs. Confirmation of ventilation is critical. Following inflation of the balloons, begin to ventilate the patient. Confirm the patient's chest rise and the presence of breath sounds. Be sure to continuously monitor ventilation. Foreign body airway obstruction. A foreign body that completely blocks the airway is a true emergency. It will result in death if not treated immediately. In an adult, usually occurs during a meal. In a child, it occurs while eating, playing with small toys, or crawling around the house. In an unresponsive patient, the most common obstruction is the tongue. Recognition. Early recognition is crucial to provide emergency medical care effectively. Obstruction by a foreign body can result in a mild airway obstruction or severe airway obstruction. Great care must be taken to prevent a mild airway obstruction from becoming a severe airway obstruction. With a mild airway obstruction, the patient can cough forcefully, although you may hear wheezing between the coughs. Continue to monitor the patient closely and encourage the patient to continue coughing. Attempts to remove the object manually could force the object farther down into the airway and cause a severe obstruction. With poor air exchange, the patient has a weak, ineffective cough and may have increased difficulty breathing, stridor, and cyanosis. One sure sign of severe obstruction is the sudden inability to speak or cough immediately after eating. The person may clutch or grasp his or her throat. A complete and thorough patient assessment is key. If a patient is found unresponsive and does not appear to be breathing, you should begin CPR with high-quality chest compressions. Suction should be readily available for any patient who is unable to maintain his or her own airway. Always assume that patients who require emergency medical care have a full stomach. Alright, that is going to be the end of Chapter 11 lecture. It is 1:21 a.m. I've been recording lecture for you since about lunchtime today, and I'm doing this while working. So I would like to know that my efforts are not wasted. With that being said, if you have stuck it out through to the end of this lecture, I'm grateful for you. And this is what I'm going to do. If you flip to the back of your test tomorrow and you write the word bonus and I don't care what, and write your favorite color. There's no wrong answer to any of that. Write the word bonus and your favorite color. That will let me know that you stuck it out to the end, and I'm going to give you 5 points on your test just for being here with me and letting me know that my work today was not for nothing. So I appreciate you. I believe in you. Good luck on your test tomorrow. If you have any questions, we're here. See you tomorrow.